And finally, on to today's webinar. If you've been here with our resilience in retirement, resilience with chronic illness, then you already know our wonderful hosts. If not, really happy that you get to experience Tamara to be here for today's topic, which is navigating the emotions of advanced care planning. So not always the conversation that we are, thrilled to have, but she's going to talk about why it's important, how you can navigate the emotions around it. And we're just really thrilled to have her back. We love that. We love when she comes here to share. So I'm going to stop my sharing and then pass it on. Thank you so much, Tamara, for being here.
Always. I am delighted to be here. So thank you for having me for a third time. Well, welcome everyone. Welcome anyone. I think there might be some familiar names in that little participants box. So that's fun. I'm excited to talk with you today about advanced care planning. We'll talk about what that even means because it's kind of jargony, and end-of-life decision making and some of the emotions around that, specifically for older adults and their families. So I'm gonna see if I can hide this little meeting controls. Can you go away, little meeting controls, please? Well, we'll go with it. Okay, so if you haven't met me before, my name's Tamara. I am a licensed marriage and family therapist in those states. And so I work with a lot of individuals, but also their families, adult children, adult siblings, spouses caring for spouses, all sorts of relational makeups. And I have a private practice called Vibrant Living. I am in Minnesota in particular, and then see people virtually in those states as well. I have I'm a fellow in thanatology, which means I have the highest level of expertise in death, dying, and bereavement. I get really nerdy about end-of-life stuff and grief in particular. And then I also teach at a couple of the masters, the clinical master's programs here in Minnesota. I, in particular, got interested in end-of-life. I grew up on a pig farm. And people always ask me, like, how did you come to want to do this as a topic? Because it's kind of a taboo topic, which is unfortunate because we're all going to die. And everyone we love is going to die. And so it's a really necessary topic for us to be talking about. So, but I grew up in a pig farm. And so I was around death because animals die, right? They're not always born and thriving. My dad would let me bottle feed the baby pigs, the little runts. He didn't tell me, by the way, they're going to die. I just learned that the hard way. And then, through pets, deaths and things like that. And my parents really did a wonderful job. Every time I tell the story, I forget I need to go and tell them that they did such a wonderful job, where we would bury our pets and we would bury animals in our woods. And we would actually put up a little cross and like have a little service for them. And it was kind of amazing. And I didn't realize till later in life, like this, we call it like death literacy or grief literacy that my parents had, that I don't think they even necessarily consciously realized. Anyway, I'm going down memory lane. I love talking about taboo topics with people, especially death, because it's unavoidable. And so we can choose to not talk about it kind of at our peril, right? And so the purpose of today's conversation is really to talk about, talking with the people that we love about what we want at end of life, what we want in terms of interventions, what's important to us. And so my goal today is to bring awareness, to the multitude of emotions that folks are experiencing when facing the prospect of making these decisions about procedures and plans at end of life. A lot of my clients either have been avoiding making these kinds of decisions or talking about these kinds of things, or that's something that we're working on together with them and their families. It is an important, sometimes delicate conversation to have, and I love facilitating these kinds of decisions. One interesting piece that I shared with Sarah before we got started today. So when I originally designed this workshop, it was actually for medical providers in Michigan, in the University of Michigan. And so the initial audience was a lot of nurses and social workers who were working in a hospital setting and a variety of clinical settings where they are bringing up these kinds of conversations with people. And so I also think that part of my mission, vocation, is to equip and demystify professionals from having these conversations, because we all kind of avoid it. And again, it's at our peril. And from a provider standpoint, it's at the peril of not knowing what your patients want and what kind of interventions they want you to be doing. And so I have adapted the content to be for those of us in the community, right, who are making these decisions for ourselves. But I just thought that was an interesting kind of like well-rounded transition of equipping providers themselves and then also equipping us. So the agenda for our brief time together today is really to talk about like advanced care planning. What is it? What are we talking about when we say that? What are some of the documents in New York? Because documentation for advanced care planning is state by state. There's different terms and different, does it need to be notarized, all these different pieces. We're going to talk about some key terms. We're going to talk about the emotions around this experience and kind of how to navigate them, and then have some time for Q&A. So that's what I'm hoping to accomplish today. So when we say advanced care planning, what are we talking about? We are talking about a process where individuals and people close to us discuss, decide on the medical care that we want. We want to make decisions that are consistent with our values, our goals, our preferences, and what we see as quality of life. Quality of life is a very subjective term. What I think of as quality of life is likely not what you think of as quality of life, right? I know for myself, I need sun, I need windows. I've got 22 windows in my 1910 year old house, or my house from 1910. So it's 113 years old, right? I need sunlight. I need cats, of which one is imminently going to join us. There he is. Like, it's like on cue. I know for my mom, she needs cats. She needs Ovaltine, so it's chocolate milk, in a glass, not plastic, glass. These are things that I know are important to her, but they're very subjective. And the thing is when we don't have these conversations, sometimes the people around us who are going to be helping us in later life, they don't know what we want. And so there's kind of like those quality of life pieces that are more, subjective and may include chocolate milk. And then there's the decisions about medical interventions. So the main ones that are covered in advanced care planning are resuscitation. So do you want chest compressions? If your heart stops beating, do you want someone to try to get it beating again? We'll hear that as like a DNR, or do not resuscitate. Intubation, which is, do you want a tube down your throat and to be on a ventilator? Dialysis, so if your kidneys are not functioning, do you want dialysis? That can be for hours each day for multiple days a week. You can say yes or no to different pieces of these. What kind of medications do you want? Do you want antibiotics for a urinary tract infection, but only if they're oral, not if it's an IV, because that is a decision you can make. And then also, what do you want done with your body after you die? So we call that body disposition. What do you want done with your body? Do you want to be buried? Do you want to be cremated? Do you want to be composted? Right? We have a lot of options now. Do you want to become, tree? There's tree pods. There's all sorts of things you can do. A ton of creativity for that these days. So when we talk about advanced care planning, it's really an umbrella term for planning for a variety of different things, but it includes medical interventions, and then kind of like what we want done with our body after death, and what does quality of life look like for us. It's really to communicate, right? Advanced care planning, the purpose of it ultimately is to communicate. It's to communicate to our family, to our friends, to our loved ones, to people who we have chosen to make these decisions for us if we can't. Right? So we're making our wishes known, and then to our medical providers so that they're able to do what we want them to do. When we think of advanced care planning, there's kind of like formal and informal. So formal advanced care planning, typically done with healthcare providers. It can be done with an estate attorney. You can do that with like someone like me, because I'm a facilitator of advanced care planning. So it's done with someone who is trained in advanced care planning. That is formal advanced care planning, usually results in a written healthcare directive, or advanced care directive, usually results in a formal document. Informal advanced care planning is the conversations that we're having with family and friends and other people that are close to us. It's not always documented. Sometimes it results in formal decisions, but sometimes it's just a conversation we're having over dinner. Well, at least for me, it's a conversation I have over dinner. I realize I might be unique in that way. And so ideally, both of these are taking place, right? Sometimes one happens before the other, but ideally both of these are happening, because it's great if we have conversations with our families about what we want, but if it's not written down and something happens, it's not as helpful, right? So that when you end up in the hospital, is there an instruction sheet essentially for the providers to use to navigate what you want if your family can't get there right away or something, right? If a decision needs to be made right in the moment, do you have a blueprint written down? And sometimes people with these informal conversations can have different memories of what was said. I know this is going to be sarcasm humor here. I'm sure that you've never experienced being in the same conversation with multiple people, but people remember it differently. Yeah, that's what we're talking about here, right? Where one daughter says, Mom would want everything done. And the other says, she said she doesn't want to be resuscitated. And those are at odds, right? So the best case scenario is it results in formal documentation. The University of Michigan did a poll. It's actually a really neat poll that they did, a national poll on healthy aging. So it was a national sample of the US, ages 50 to 80. And what they found in terms of advanced care planning, they looked at a variety of things, but 59% of people who responded have talked with someone about the medical treatment they wanted or don't want if they were seriously ill. 59%, it's pretty solid, right? 29% of those had done so in the first 3 months of the pandemic. So we remember this pandemic deal. We remember that by and large, the majority of people, especially who were dying initially, were older. And so I think what happened is that people went, oh no, what do I want, right? I need to plan. So 46% of the people who responded to this have a medical durable power of attorney or advanced care directive. So that's just magic words, jargony words to say they had documentation. They had named someone that they wanted to make decisions for them if they couldn't. And of those 46%, 7% had completed that within the first 3 months of the pandemic. So again, it kind of spurred people on to make some choices. I like to kind of intersperse some of what I do with some literature. So what this particular study from 2021 found was, we know that advanced care planning becomes more important. It also becomes more frequent or prevalent with age. As people age, they're more likely to engage with formal documentation, which makes sense. Those informal conversations among family are important. They can be helpful, right? There might be less conflict when decisions are actually enacted, but without formal conversations and documentations, those wishes might not be followed. And one of the important pieces that this study found is that they have a theory that older folks might be more active in initiating this process of formal advanced care planning if they had more realistic expectations about the estimated life expectancy. So we kind of go like, oh yeah, well, I've got cancer, but yeah, I could live for a really long time with it. I think one of the important pieces here is that comes back to open and honest, realistic communication from care providers. That is a piece that I made really clear when I was talking about this with people in Michigan. Those providers in Michigan was being honest and realistic when you're talking with your patients about what their prognosis is, which is challenging because we don't know exactly what's going to happen with a disease process, even when we're familiar with stomach cancer or something like that, right? So there's this balance of realistic information and then kind of how that impacts our ability to do formal documentation based on what we know of what's going on in our bodies. there's kind of like individual motivators and interpersonal motivators for advanced care planning. I thought this was kind of neat. So in this study, the highest individual motivations were a desire to receive end-of-life care that was concordant with preferences, right? I want my choices to be followed. The second most common one was a desire to reduce suffering at end of life. That makes sense. None of us want to suffer at end of life. And the third most common individual motivation was a desire to ensure that the care that we received was in line with our religious or spiritual preferences, which again, we need, with any of these choices, need to make known what those are. Interpersonal motivations that people talked about in terms of motivating them to do advanced care planning was, 85%, a desire to ease the decision-making for other people. A lot of times people will word that as, I don't want to be a burden, right? I want my kids to know what I want. I don't want them to have to make these decisions when they're sad, when something is happening to me. I often talk with clients about like advanced care planning is ultimately a gift that we give to our children, to our families, to our communities, whatever, of here's what I want. And then they go, okay, I will follow it. Instead of, you have a stroke, they don't know what you want. And now they're like, oh no, what would mom want? And then there's conflicting ideas, right? She'd want to be resuscitated. She wouldn't, all this stuff. It's just, instead it's like, here it is. The decision-making is easier because you know what she wants. And then another top interpersonal motivation was a desire to reduce financial costs at end of life. That's huge. We have the data. We know that the large chunk of Medicare costs take place in the last, I can't remember if it's the last 6 months or the last, imminent last months of life, is tremendously financially expensive. And often on care that people don't want. And so we need to be able to be talking about what we want and what we don't want. In that study, only 28% of the people that responded indicated that their provider had brought this up. Eek, right? I talked about that with those medical providers of like, folks, you need to bring it up. You need to, if you're working, especially with older adults, but I have an advanced care plan, I'm 36, right? I still want people to know what I want in case, God forbid, something happens. And so it's the importance for providers to be broaching this subject. It's part of their job, really, I would say. Whether or not they see it that way, it's part of their job, not just to talk about the care that people are going to receive, but the care that they don't want. We also need to know about the care that we don't want. Oh, it's like I preemptively knew that the slide was coming up. Because healthcare is not just about the medical interventions that we provide, but also includes what we choose not to do. And kind of what happens in healthcare is the answer is assumed to be yes, I want that intervention, unless you are very clear that the answer is no, as in it's written down. The answer is no. And so if you don't have a DNR, you're going to be resuscitated because the EMT that gets to your house, that's their job, right? Is to save life. And they don't know you from Adam. They don't know that you are 85 with osteoporosis and that you actually are good to go and you don't want to be resuscitated. They don't know that unless you have documentation of it. There are some family dynamics that go into again, talking about advanced care planning. Some of them include family members not agreeing on medical decisions, maybe a family history of not wanting to talk about hard things. I'm sure that never happens in your family. Varying degrees of involvement, right? Estrangement, maybe, of some adult children, long distance caregiving, folks saying like, no, I know what mom would want, but I haven't been home in 5 years and I haven't talked to her in a long time. Grief. Whew, grief. We'll get to that. I think we get to both grief and guilt in terms of advanced care planning, but this can feel like letting go, right? It can feel like acknowledging the loss before the loss has happened. We're acknowledging the reality of the illness, potentially. And then also guilt about, timing and all sorts of things. Varying degrees of involvement can induce guilt as well. So advanced care plan documents for New York, because as I mentioned, they are state to state. I've got links here for you. I'm not going to get into the nitty gritty about them. because as I mentioned, they are state to state, and I am in Minnesota. I am not in New York. And so I'm not going to say that I know the ins and outs of all of the process in your state, but I did get the documentation for you. I sent it to Sarah, so she'll send that out along with the slides from today. However, there are overlapping things within any of these directives. They are going to include similar topics, such as what they call a healthcare proxy, which is medical power of attorney, whereas that person that's going to make decisions for you when you can't. Do not resuscitate is not, no chest compressions. Living will, which will include other components of the end of life decision making that you want. And then in New York, it's called a MOLST, which is medical orders for life sustaining treatment. That essentially takes your wishes and makes it doctor's orders, which is a little bit more surefire that they're going to be followed. Usually we don't have a MOLST, or in Minnesota, it's called a POLST, right? Gotta love it, acronyms, which is provider's orders. Usually we don't have that document unless you have like a chronic illness or a terminal illness, something more serious. In my situation, I'm a healthy 36-year-old. I have an advanced care plan because I want people to know what I want, and all adults should have advanced care plans, but I don't have a POLST or a MOLST because I don't have any sort of life-limiting illness that's happening. So all of this to say, these links here are here for you to reference, to look at, to foster some conversations with your family, and also to bring up with your care provider. The advanced directives can be done by you on your own. Every state is a little different in terms of, does it need to be notarized? You should talk about it with your care provider as well. The difference with a MOLST is that needs to be signed by a medical provider. So they're a little bit different. And if you have a life-limiting illness, you should have both. If you are a healthy person or healthy enough, whatever that means, you should have at least advanced care plan. So I also included some terms to know, even though I got ahead of myself and just already told you what they are, but they're here for you for later. So I already told you what all of these things are, and this information is from that New York government website. These aren't my words, they are the New York government's website's words. And this is just the information I already told you because I got excited and told you all about it already. So just more for you to reference down the road when you're talking about this with your family. I did also take this information from that document where it talks about the differences between palliative care and hospice care, because they can be kind of confusing for people. So I mean, I usually do entire workshops on these topics of palliative care and hospice care. So this is like the quickest. But palliative care is this multidisciplinary, multiple member team where people have a life-limiting illness. They are not necessarily toward end of life, but it is a team approach where people can get relief from symptoms. A person is named who can also help make decisions with you as well. But it's a care team that can help you as you're going through. If you have cancer, it can help you as you're going through chemo, right? And be kind of like a well-rounded care team while you're seeking curative care. Hospice, on the other hand, is another multidisciplinary wraparound team where they're providing this comprehensive care when you are terminally ill. They provide this supportive care in addition to, it's kind of like in addition to palliative, which is focusing on comfort. When you are experiencing hospice care, receiving hospice care, you're no longer seeking cures. So you're no longer seeking chemo. You are seeking comfort care measures. So pain management, that sort of thing. Hospice care programs are regulated under federal and state law. Interesting fun fact, in New York State, there's about 50 hospice care programs. That is fabulous. And so you can indicate if you have a preference for a hospice program, if you have experience, or maybe you worked for one, that you want services through. That's the fastest. Oh, there we go. There's more information. I was like, it's the fastest I've ever gone through about hospice care. It is generally a covered benefit you have 6 months or less. That's kind of the criteria for hospice care, 6 months or less to live if the disease process that you have would continue on at its normal course. And physicians have to certify you that you're appropriate for hospice care. You can receive hospice care wherever you are. So your home, it's not necessarily a place that you go. A lot of times people think that I'm going into hospice, as in I'm going to a place. You can be at your assisted living, at your apartment building, in your single family home. And so has a coordinated medical team, and it is also generally covered by insurance. It is part of the Medicare hospice benefit, and it is also typically covered by private healthcare insurance as well, if you are not at the point of being on Medicare. Okay, that's the logistics. Now we're going to talk about the feelings. And so I talk about emotions really as like signals, are signals that our bodies and our minds and our, our beings are telling us about what matters to us. So some of the emotions that can arise when we are experiencing having to make decisions about end of life, there can be confusion. Okay, so I go through, I think, like 7 emotions. They're in alphabetical order. They're not in any like order of frequency. They're in alphabetical. So confusion. People experience confusion when there's an unclear diagnosis, when there's an unclear prognosis. So prognosis is kind of an estimate about kind of how the disease process is going to go, maybe how long you have left. We call that prognosticating. Prognosticating, which is that what our doctors do, our providers do when they estimate our length of life or how things are going to go, is very challenging, because there isn't just like, oh, and here's the end date, right? We don't know that. And so it's a best educated guess. It's the best informed educated guess. There can be confusion when there's lack of communication from providers, or miscommunication from providers. If different providers, if your cardiologist isn't talking to the palliative care team, there can be confusion about what documents to complete. What are the requirements? Are there signatures required? Does it have to be notarized? Where do we put it on file? Is it necessary to put it on file? What does that mean? Who all needs to know about it? Confusion about care options, right? What are the benefits and drawbacks of each option? What would it look like to be resuscitated at 85 with osteoporosis? I can tell you, not good. We can break ribs, right? Like generally not good. And so confusion, mostly you can tell through the lens of information, right? Unclear information or not enough information. Fear about our own decline and death. Like even if we're caring for someone who is the person who is ill and is dying, it brings up stuff within us too. So fear of our own, fear of our loved ones' decline and death, fear of making the wrong, air quotes, wrong decision, concern about deciding too soon, or, people talk about like pulling the plug too soon, fearing about timing, right? Deciding too late. Oh, I wish we would have got around to hospice sooner. This is such a helpful service. I wish we would have had these supports sooner. We waited too long. And so fear about timing is a common emotion. Grief, there's this, concept of anticipatory grief. So where we're grieving in advance of something that is likely to happen, and not just death related. Grief is so much broader than death. I'm a grief nerd, so like, don't even get me started. We don't have time for me to get started about grief, so I'm just going to focus here. But grief about your own decline and death, grieving the person that you are caring for who is declining and dying, and envisioning your life without them. Grief about time that you lost in the past. I wish we'd made more of the time that we had. I wish we would have gone on that trip. Grief about time lost in the future. We grieve things that have not happened. We grieve, it's called a loss of dreams. I have clients who, go into retirement and then are diagnosed with cancer, terminal cancer. And they're like, oh my God, this is not what retirement was supposed to be. So kind of what you had hoped for in the future not happening, or a limited time that you thought was going to be longer. Guilt. People who live out of the state or out of the country often feel some amount of guilt for not being present and not being involved. Even people who are in the state can feel guilt over a concern about not being involved enough. Did we do enough? And I mean, I even have air quotes over enough, because that is a very subjective term and can really be a place where people beat themselves up. Did we do it right? Another very subjective term. And both of these can be sort of assuaged by information and having some guidance. There can be relief. Like, I'm not here to just only tell you sad things, though by and large, that is usually what I end up doing. This presentation isn't as hopeful and about stuff as the resilience ones, but really being able to acknowledge your emotions and honor them will build resilience. So it's all tied together. But there can be relief in advanced care planning, knowing what your loved one wants, having a clear path to follow can be a relief, because it's like, I'm not guessing, right? I'm not guessing what this person wants as we are making these decisions for them. Oh, they're not an alphabetical. Well, they're adjacent to alphabetical. R comes after P, but there can be pressure. There can be pressure about time, right? So discussions that are happening during a terminal illness rather than before or at the time of diagnosis, we can have a sense of limited time to make these decisions. Or there can be a pressure, maybe by providers, if they're not giving us enough support, especially if they're also saying like, we need to know what you want, but they're not giving us enough information. They're not giving us enough time to make these plans, to make these decisions. There's a sense of responsibility, a heavy sense of responsibility. It can feel like a burden of decision making. So, kind of one of the pros of being proactive in end of life planning and advanced care planning is it eases some of this responsibility of our family. And so, but the sense of responsibility, there's a desire for this responsibility to be shared with providers, right? Not just on us as the family or on the patient, but is there some responsibility of the provider to be having these conversations with us, and responsibility of the provider to be giving us information? I would say there is. And then uncertainty, right? Ambiguity, uncertainty about what the future holds, right? About how much time we have left, about what the decline might possibly look like. And then also a sense of uncertainty of, will our decisions be right? Air quotes. What is right, right? Will we make the right choices? That is one of the things that advanced care planning can help kind of assuage, is being able to have decisions laid out. We know we can make the right decision because we've heard what mom wants. So where do we go from here? Well, what do we need from providers, right? And which emotion does this impact? So when I originally designed this training for providers, this was like, here's your call to action. Hospice or hospital social workers, hospital nurses, hospital providers, right? Here's what we need you to do. But I'm going to flip it on its head a little bit and just say, okay, here we are, individuals, right? We sometimes need to advocate for ourselves and advocate for our needs. And so what do we need from providers? And which of the emotions that we just talked about, where does that impact? We need clear, honest, timely communication, because that helps mitigate our confusion, right? Our sense of responsibility, our sense of uncertainty. We need providers to be honest about testing results, the likelihood of the accuracy of the diagnosis that they're giving us, because that helps with confusion, fear, and uncertainty. We need providers to be as clear as possible about the likelihood of what the different outcomes might be, including timeline and death. That helps with the confusion and the pressure to make these choices. We need folks that are going to open the dialogue sooner than later, because that helps with the time pressure and our sense of responsibility, that it'd be more shared. We need to have documentation options. We need providers to have documentation options on hand, and for them to have knowledge of the requirements for the state or their care system. It helps with confusion and responsibility. We need providers to have an open dialogue with us about end of life care and the options, having honest information about the success and challenges of each intervention. We need providers to be honest with us about what is it like for an 85-year-old with osteoporosis to get resuscitated. It gets at that confusion, guilt, fear, responsibility, uncertainty. We need facilitative, supportive conversations with us about our values and our dignity at the end of life and what it means to us. That attends to that fear, grief, guilt, uncertainty. And we need folks to facilitate a balance of planning ahead and also supporting in the moment decisions, because sometimes the plans that we have put in place maybe have kind of changed if they're a new diagnosis. And that gets at that confusion, fear, guilt, pressure, responsibility, uncertainty, right? And so I think it's kind of like a two-pronged approach that I try to take here in terms of educating providers on their roles and what can be helpful in advanced care planning. But also I say this information to you because part of our experiences as people is to advocate for our needs. Sometimes it's disappointing how much we need to advocate for ourselves in the care system. And be that as it may, these are some ways that you can advocate for yourself and for your loved one. If you want to get nerdy, those are the references that I use. I do want to say one thing. It is a personal story, but it gets at some of those pieces around uncertainty and confusion. So I share this during the resilience in chronic and terminal illness presentation, but for anyone who didn't hear it there, or if you did, you're just going to hear it again. So I am obviously very passionate about this, and I had been kind of badgering my parents to do their end of life planning for a relatively significant amount of time, and then they did. And so, you know, we've got their advanced care plans in place. Neither of them have a chronic or a life-limiting illness, so they don't have a medical orders for life-sustaining treatment. They don't have the doctor's orders in place because we don't need that yet. But they had their advanced care plans. So I know what my mom wants. It's clear. Okay. So my dad, we're not as, you know, this isn't as much of a topic that we've talked about. So I was looking through his advanced care plan and it kind of surprised me. He said he wouldn't want to die at home. And I thought, oh, that's really, you want to die in a hospital or like a nursing home? Gosh, I mean, okay. You know, I want to honor his choices, even if it's confusing to me. And he said he wanted to be embalmed and buried, which I was also curious about. My parents don't belong to a church that has a cemetery or a graveyard. They don't have plots bought, and my mom wants to be cremated. So there's some dissonance here. And so those wishes were on there, and I was kind of like, And so this is probably like 6 months ago, over dinner, because that's how I roll. I somehow got on the topic of, you know, I want to be, my plan is to donate my body to the local research university for their use. And so that's an anatomy bequest is what they call that. And so I was talking about that. And then I, of course, you know, because it's who I am, I was like, Dad, question for you. And this is literally like, I'm relatively quirky. What you see is what you get. I'm wearing my overalls that have little succulents on them because it's finally springish in Minnesota and I am here for it. So I'm relatively quirky. So what I'm about to tell you is like probably verbatim what I said to my dad. I said, Dad, question. So on your advanced care plan, you said you don't want to die at home. Can you tell me more about that? Which is like very therapist-y. Tell me more about that. And he's like, well, yeah, I don't want to be a burden. And I said, oh, don't worry. Okay, good to know. We will get hospice care. No worries about that. Okay, here I had been taking that to mean, you know, he didn't want to die in his own bed, or he didn't want to be in the house, or something about the care he would receive at a hospital. You know, I was taking it to mean something very different. And no, I don't want to be a burden. I said, oh, don't worry about it. We'll get hospice care. Not a problem. And I said, follow up. You had said you wanted to be embalmed and buried. Can you tell me more about that? And he's like, oh, well, you know, I want to end up in the ground, you know, for the worms. And I said, oh, got it. Okay. Well, here's the thing. The worms aren't really going to be able to get to you. Like if you're embalmed and buried, you're like in there, you know, kind of like pretty closed in, possibly in a vault, like a cement vault. Like you're like pretty pretty enveloped in there. And so I was like, well, that's not really how this works. Okay, good to know, good to know. And you know, I kind of was just like, well, it makes sense, you know, he's a retired farmer, he wants to go into the earth. And I said, oh, the worms. Okay, I said, so what I'm hearing is you want a natural burial. Well, you know, whatever gets me to the worms. And I said, oh, okay, you want a natural burial. So all of this to say, it's not just the documentation. We need to be talking about what people are putting on the documentation, because my friends, if I had just followed what my dad wanted without actually talking to him about it, he actually wouldn't have received what he wanted, right? Like, he wouldn't have received it. And so it's so important to not only have these documents, but to talk with the people around us that are going to be actively part of this experience and part of this process when we start to decline and die, so that they know what we actually want. Because my dad had different ideas about what these questions meant and didn't have quite the whole rounded picture about what options were available to him until we started talking about it. So it's not just documents, it's also communication. I think I'm satisfied now. So I think I've said my words that I had planned to say. Thank you for listening. Thank you for being interested in this topic. I am just so delighted to be able to share this information with you. If you have, you know, any questions, you're welcome to reach out to me, but there'll be more resources and these slides sent out to you by Sarah as well.
Yes, thank you so much. You took the words out of my mouth. In case anyone didn't see in the chat, we are going to send out these slides, and very thankful that you were able to pull the New York documents as well. We'll send that. And if anyone's outside of New York, I'm fairly certain if you go to your state government's health department website, you'll be able to see those specific forms, and there's a lot of resources on there as well. So if you're in like New Jersey or anywhere else, just go to the state health department website and you'll be able to get the documents as well. But we will send out everything that she's pulled for us, and you'll all get that as well. This is great. Thank you so much. We do have a few questions, so I'm just going to get to them real quick. So the first question, can you talk about PEG tubes to feed and hydrate for those who cannot swallow? Because that's another kind of intubation. So if that's, I mean, I don't know if you want to get too into the weeds about it, but if that's like an end of, you know, if that's another thing that you have to get a little bit specific about when it comes to your care.
Yes, absolutely. It absolutely is. And that's a great question. And I got to be honest, I got to add that to my slides. So thank you for bringing that up. So we call that artificial nutrition and hydration is kind of what we put that under. And yes, if it's not, depending on your document, if it's not automatically called out, that is something that you should include. Most of the times it is called out. And so whether that be, yes, artificial nutrition and hydration. So it is a decision making, do you want a feeding tube placed? And sometimes people say yes, sometimes people say no. This is another place where you'd really want to get advice from your provider as well, because there are some, I mean, it can be kind of uncomfortable. And what is the long-term prognosis? You know, if we're looking at a terminal illness, what does that look like exactly? Kind of weighing quality of life and the realistic nature of a disease process. I'm not going to get too far into the weeds about any of these decisions because they're so subjective, depending on the illness that you have and the approach that you want to take. And so it's that balance of with any of those choices that we listed there, it's the balance of, you know, what is your diagnosis? What is the outlook for it? What kind of care do you want to receive? What are your goals? What's realistic? A lot of information you need from your care provider. But then even within all of that information, it's subjective. You get to make choices. And so, absolutely, there's a lot of subjectivity there. But thank you for bringing that up. I'm going to make myself a note to add that to my slides. Thank you.
A plus student. Yeah, and I think it's also, you hit on that good point about talking to your doctor. You know, intubation can mean a lot of different things. And so it's like, you know, it's not just one scenario. So I think that
Mm.
clarification of just asking those questions, and you said it beautifully about you need to advocate for yourself. I feel like we say that in probably all the webinars that are related to any kind of like health of any kind. But if you're confused about what something means or different scenarios they might, where that might come up, it's helpful to have those conversations so that you can understand what, you know, what something might look like in a certain
Yes.
situation. That makes sense.
I will add a piece
Great.
to that too. So one of the things to just consider when you're doing this advanced planning, we can't plan for every scenario, right? So we will not be able to, as human beings, we can't plan for every scenario. So we won't be able to say, I would like a peg tube in this scenario, but not that scenario, da, 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 da. So one of the great things about advanced care planning and having these discussions and documents is you write down your values, your wishes, your quality of life, so that if you say, I don't want to be in pain, that is also part of the blueprint for that. Okay, I don't want to be in pain. Would XY decision put me in pain? So that when the rubber hits the road and my proxy needs to be making choices and they read, she doesn't want to be in pain. They ask the provider, what's the outlook on pain for this? He goes, not good. Okay, well, that informs the decision, right? So it's like a very well-rounded document that doesn't just try to get at all the scenarios, because we can't possibly get at all the scenarios, but what fills in the gaps in that way is stating what's important to you and what quality of life looks like for you, so that they can see through that lens, this is what she would want in this complex scenario that we couldn't have planned for.
Right. So it's almost like an umbrella.
Yes.
You know, an umbrella policy, if you will.
Yes.
Amazing. Okay. So someone did bring up, are medical professionals aware, I believe, that Medicare covers end of life discussion with patients?
Are they aware? I mean, I know that. And it's great that Medicare does that. I don't know that every provider knows that. There is a shortage of folks, providers, medical providers that are skilled in working with older adults in particular, which is the most common, right, Medicare recipient, and also the most common age bracket that is going to be doing this type of documentation. So I will not make a broad statement about what providers do and do not know, and I won't get on my soapbox about what they may or may not know. I will probably say, though, with pretty good confidence, not enough know about that. And even if they do know about that, not enough are doing it, which bears out in that data that you saw from 2021. 28% of the respondents had said that their provider brought it up. Right? So I think we can interpret to some extent from that data, they either don't know that they get paid for this as part of their visit, or some other barrier is happening for it to get brought up. And this is not to point fingers at or vilify providers in any way, shape, or form. There's a lot of logistics and also emotional reasons why providers don't bring this stuff up. And also it's a training issue too. And that's a more broad thing. And that's actually something that's really exciting. I'm on a task force in Minnesota, an interdisciplinary task force, to get providers in the medical school and other interdisciplinary better trained in death and dying and what it looks like and how to have these conversations. So the good news is, and I'm sure that's happening in other states as well, the good news is we're working on that, because as death literacy, death education, death awareness continues to increase, we know part of the problem is that providers aren't getting the training that they need to be comfortable and competent to have these conversations. So we're working upstream to get them trained to be able to do that, so that this is happening more often and then people's wishes are being respected.
That's great. And I think on top of, you know, hopefully professional providers will get more information about this, you know, now as an individual that Medicare can cover this conversation as well. So that's more information for you as well as the individual. Okay, so we have two more quick questions. Somebody asked, what if you're struggling with a family member who avoids this topic every time it's brought up? How do you recommend handling avoidance?
Oh, that's like, I love that you stipulate that they're quick questions and then they're like, oh, it's really not a quick question, but okay. I appreciate you, Sarah. It's so tough. I mean, I think I feel like I'm going to be a broken record about this one. I feel like I say these words every time we have a webinar. Compassionate curiosity. There's something that is holding them back from talking about it, whether it be fear or it be, we can have the sense of like, if I talk about it, it'll happen, which isn't really how it works, right? Talking doesn't cause cancer, like it doesn't. And so there's something that's causing trepidation for them to want to talk about it. So can we just kind of like be gentle with them, be gentle with ourselves? Unfortunately, not everyone is going to do this. Not everyone is going to want to talk about it. And so, as I say, probably every time, I'm not always the bearer of good news. Sometimes I'm usually just the bearer of bad news, but it's honest. They may never want to talk about it. They may never talk about it. And when the stuff hits the fan and there's a crisis, you might be faced with some challenging decisions. But that's where, even if it's not written down, we come back to, okay, Mom never wanted to talk about this, so we don't know exactly what she wanted, but what do we remember about her? What do we know about her values? What do we know about what was important to her? That's stuff we know, right? So even if they won't say, I don't want to be intubated, we can come back to this knowledge of like, I know Mom would not want to suffer. I know Mom wouldn't want to live long-term on a ventilator with dementia, right? So we come back to what we do know about her, even if she didn't give us this documentation and didn't have this conversation with us. We fill in the gaps where we can.
I think that's great. And I like you said, we can't force people to have these conversations. And so we do the best we can with what we know. And if people are open to talk about it, then we can get this information in writing, but we can't force it. So it has to be compassionate. Yeah. Understood. Okay, so last question, then we have to hand it off to Circle of Care to chat. Somebody asked, are hospice services regularly available for those with an incurable progressive illness, but no set time left to live? So something like a neurological degenerative disease.
Oh, solid question. As I understand it, generally no. So, you can have, neurodegenerative. So if we're talking about like a form of dementia, we know with any form of dementia, you can live with it for a very long time. And so you could potentially ask about palliative care. That one I'm a little less familiar with. I've worked in hospice. I'm a little less familiar with the ins and outs of getting certified for palliative care, but I'm pretty sure that the 6 months or less to live for hospice care is pretty clear and pretty, I don't know what the word, ironclad, I don't know what I'm looking for, but it has to be pretty clear. Now, granted, like we talked about, prognosticating or estimating times of life is very challenging. So sometimes people will go onto hospice services and then 5 months later and they're reevaluated and they say, yes, still, if this disease process continued at the rate that it is, so they recertify is what they call it. Sometimes people get on hospice care and they get better. Not that the disease goes away, but because they have this well-rounded support, sometimes they get better and they graduate, which is a confusing term, but that's the jargon. They graduate from hospice. And so, but they can be back on it again. So my understanding of it, always ask. There's no harm in asking and being told, no, that doesn't qualify. And then I always say, follow up with, when should I call you back, hospice company? What should I be watching for? When should I call you back? And then they'll tell you. But my understanding is that 6 months or less timeline is pretty strict-ish. Yeah.
Okay. And I think, like you said, it never hurts to ask. And if it's a no, then maybe they'll have other resources for you to use. But
exactly.
It seems like it can be a fluid conversation. I think that's all we have time for. Thank you so much. Someone said suggestions, I think in response to avoidance, show reluctant people this video, which I love. Yes, it'll be on YouTube. You can share it. Love that suggestion. And anyone who's dealing with trying to have these conversations, we send our, strength and resilience to you. And just really appreciate, Tamara, you for being here and sharing your knowledge and your stories and everything. It's been such a pleasure to have you. And we just really appreciate you coming back to chat with us.
Always lovely.
Amazing.
Thank you for having me.
Thank you. I'm going to hand it off for these last few minutes to Kiara, who's going to talk about Circle of Care, a little bit more information. If you do have any questions about Circle of Care, you can put those in the Q&A box as well. And I'll just let Kiara take it away.
Thank you, Sarah. Good morning, everyone. My name is Kiara Soto. I'm the intake care consultant at PSS Circle of Care, and we are a caregiver support program that offers free services to those caregivers who are caring for a loved one who is chronically ill, suffering from memory loss or dementia. And these services include counseling, support groups, educational trainings, respite care, advocacy, and assistance with long-term care planning. If you'd like to find out more about our program, you can give us a call at 866-665-1713, or you can also visit our website at pssusa.org. Thank you for your time, and I will be placing our information in the chat. Thank you.
Thank you. Yeah, if you have any questions for Circle of Care at this moment, feel free to pop them in. I am going to, because I did mention that they can share this video, this recording of this video after, and I realized I didn't link the YouTube channel. So I'm going to put that into the chat box, and just so that, oh, thank you, Kara. Yeah, so all the Circle of Care info is in the chat as well. We're just going to throw all the resources at you. This is the YouTube channel where you can find our past events. This one will be up probably in a few days. And yeah, if you have any questions, feel free to let us know. Oh, someone said in response to Circle of Care, great organization, have been a big help to me and my mother. Love that. It's wonderful to hear. It is a great organization. Caregivers need care. So, and especially after we talk about these conversations, you need to take care of yourself when you have these conversations as well. So 100%. Okay. I think that's it. I think if you have any questions, for Tamara or for Circle of Care, you can reach out. Like I said, we'll send the slides, so you'll have that information. Circle of Care is always here for you. And just thank you all so much for joining us and being part of this lovely community. Thank you, everyone. Have a great week. We'll see you in the next one. Thank you.
Bye.
Bye.